What's up, everybody? This is Dr. Jose Mariscal with the Super GP Dentist, and today I just want to do a quick video about a dental implant, just a start to finish dental implant, tooth number 19. I just want to share some of the knowledge that I have with my experience with dental implants, and the aim of the Super GP Dentist is to share our knowledge, and I hope to learn from you guys, and I hope that you guys can learn from us as well, you guys. So enjoy.
Alright, so let's get started here. So we have tooth number 19 with furcation involvement. Tooth needs to be extracted. We remove the tooth. We place some freeze-dried bone allograft and rehab immediately after extraction. And then 1 month later, we got some new bone growing in the area. And then there we go, soft tissue after 3 months of healing. We got a nice wide ridge to be able to place an implant here. So let's get started with the surgery. So here we're going to go ahead and just make incision just right at the mid crest, right there in the middle of the crest of the ridge there. And usually with my incision design, I like to do just basically a trapezoidal shaped flap on the buccal and then extend it onto the lingual portion here. So you'll see me do that. And usually what I like to do is I like to go, just twice over my incision line, because sometimes you'll make the incision and it doesn't go like deep enough. So I always like to just go over the incision twice there, and you put some just firm apical pressure over that area to make sure that we get it all the way down. Even then, sometimes you'll have some struggles, but just go over it twice, give it some firm pressure, just go over right over it, just like that. You can see that I'm putting some good pressure there. And then we're going to go ahead and just do a full thickness mutual periosteal flap here once we get in there. And I think I struggle a little bit here. Sometimes it goes real smoothly. Sometimes you'll see that the tissue's a little tighter. Sometimes it's just stuck onto the bone a little bit harder, and sometimes you have to kind of fillet some of the tissue. I struggle a little bit, but we're able to get in there and create that flap. And then once you flap it on the buccal, then you can extend using the periosteal elevator onto the lingual portion here. There we go. You can see that it's a little bit of a struggle, but it worked. And the key here is having a good assistant too. The assistant can actually get in there and suction well, because sometimes it's difficult to see when you're first starting off and getting into implants. But we got that little extension there and that little extra piece of tissue there. And then what I like to do here is I actually mark my burr. I was doing a 10 millimeter implant in this case, and you can see that little notch I created there in the burr. And just going in with the surgical handpiece, of course, just to make sure we don't get any air into the tissues there. And then I go straight down with firm apical pressure. And it's important just to go straight down the position there, because I have my associate, when I was training her, she was actually doing it in like small little circles, and it actually doesn't allow you to take a good X-ray once you're ready to just check your parallelism once you take the X-ray there. So I remove the burr and I just use a surgical round burr there and put it in, and I take a quick X-ray on that area there just to confirm my angulation. And then we can get started with the surgery. So I use Implant Direct interactive implants, and I actually have my assistant suctioning there, and she's also using air water syringe, just water to keep the instrument cool. You can use chilled saline. I do that sometimes. But sometimes it's just a little quicker to use the air water syringe there, but you can definitely use chilled saline in that area. But Implant Direct is a great implant system. I just go straight through the burr sequence here, the drill sequence, sorry, all the way down. And like I said, we did a 10 millimeter. It's a 4.3 by 10 millimeter interactive implant. Here you go. Just right down to that area with my last drill. I believe the final drill for the Implant Direct system is a 3.8 diameter, and the final implant diameter is 4.3 millimeters there. So just keep the drill nice and cooled with the water, and I think the RPMs is around 1200 RPMs, and that goes the implant there. We're going to go ahead and insert it using the implant setting on our motor. Just get it down as far as you can. Typically, if you get we undersize the osteotomy with the Implant Direct, so you'll get it to torque into place pretty well most cases. And then we'll go ahead and hand crank it once we get past a certain point there. So it just torqued into place there. And usually with you know, with these implants, I like to, you know, basically back them out a little bit if they torque in too high, and then kind of go back and crank it back down. And what that does is it actually helps you kind of expand the bone a little bit, because if you torque out at 45 with the motor, this allows you to go in a little deeper. You're going to go in a little bit harder, but that bone is actually expanding slightly in the ridge there. And so here you can see me doing that. I'm just kind of backing it out little by little, putting it back into position. And I got that little flapper tissue that I was too lazy to remove with the scalpel there. But we'll go ahead and just do, I think I'd do a little bit more right after this, and then we'll go ahead and put a little healing abutment over the top, because it cranked it and tight, it was nice and tight there. But here we go, crank it a little bit more. And just make sure, usually with Implant Direct, I like to place the interactive system. I like to place these like 1mm subcrestal. There goes the healing abutment. You can see it there. You got to be real careful with these healing abutments, because sometimes they can fall out of the actual hex tool. And sometimes you actually want to torque these down. Well, actually most times I torque them down using a torque wrench, usually like 10-15 centimeters, because I do get sometimes where they come loose on me there with patients. Sometimes their tongue or brushing sometimes will cause those healing bolts to come loose. And then we're gonna suture this down. I use plain gut sutures, just common sutures here. Do a little figure 8 just to kind of seal things off. Sometimes if you lack keratinized tissue, you can actually, you know, de-epithelialize a portion of it and kind of tuck it in there. In this case, he had really good keratinized tissue, so I didn't need to do anything creative there. But we sutured it down, figure 8, cut the sutures down, and then surgery's done. And we'll prescribe the patient some antibiotics, pain medications. And here goes the x-ray immediately post-op. And then 3 months later, we'll go ahead and take an impression using our impression coping. Here we have the stock abutment with the little notch in it on the buckle, just to show exactly where we're positioning it. That's not a cavity, by the way, on number 18. And then here we go with the final finished implant crown with the stock abutment in place. And in this case, I actually used my Glidewell IO mill, and I used a zirconia crown. It was actually my first one that I did with the Glidewell mill. And here we go with the final results. So we can go from having no tooth and being toothless to having a tooth in place there. And the patient was thrilled with the results here. So, all right. So if you like what you see, guys, just please subscribe to the channel, smash that like button, and leave a comment. Let us know if there's anything you guys want to see in the future. Thanks for watching.